This morning, I'm very pleased to welcome Dr. Kara Hoppe. Dr. Hoppe is a Wisconsin native. She completed her OBGYN residency and MFM fellowship at the University of Washington before joining the department here at Wisconsin, where she's now an associate professor in our MFM division. She completed a master's degree in clinical investigation and is currently working towards her PhD, while also serving as acting medical director of the Perinatal Center. Hard to believe, but in addition to all of that, Dr. Hoppe is active locally, statewide, and nationally with numerous research projects. Her research interest primarily focuses on pregnancy and young adult hypertension, as well as preventative cardiology. Additionally, she is serving as lead physician advisor for the Wisconsin Perinatal Quality Collaborative on their statewide hypertension project. So please join me in welcoming Dr. Hoppe this morning.
Thanks so much for that warm welcome. Hopefully you'll enjoy this talk, and it incorporates both, recommendations for kind of clinical care, but also, weaving in the research and kind of pathways forward for the people we care for. Some basic learning objectives. Number one, we should know how to classify hypertension. Number two, outline current recommendations for management of non-pregnant and pregnant young adults with chronic hypertension. Number three, we'll discuss the recent CHAP trial publication and recommendations for practice changes. Here's just a list of some financial disclosures. So I was trying to weave through why should an audience like you all care about this topic? And this is a bit more kind of like from start to finish in someone's life, but you have a baseline. Everyone has a baseline, and then you might have a pregnancy that comes into play, and you have gestational hypertension, and then that pregnancy ends, and someone might say, well, maybe you have pre-hypertension, and then that leads to chronic hypertension. And then we know that these kind of pregnancy-associated outcomes are associated with long-term cardiovascular events and death. So this is just one example of a timeline, but how all of us interface with this timeline and why this is such an important topic. So really just to try to define the population that I'll focus on today is mostly the childbearing years, which, I was trying to find definitions for these classifications, but really it's 12 to 51 is the childbearing years, and young adults between 18 to 39. It'll kind of become apparent why that kind of age category is defined, but those are sort of the ages that I interface with most, but that also impact a lot of the care that we provide for the patients we care for. And then I'm a visual person, so I try to put in figures to make points, but the figure to the right really is looking at the mean age that people are birthing their babies these days. So as you can see, on the year axis from 2000 and beyond, that women are getting older when they're having their first babies and subsequent births, which also contributes to more morbidity for the women, when they start interfacing with prenatal and pregnancy care. So nearly 1 in 5 young adults, that age category 18 to 39, has hypertension, which leads to having hypertension longer and an increased risk of heart failure, stroke, and chronic kidney disease. And only 35% of hypertensive young adults actually achieve control. And so again, on the bottom, there's just visuals like the 1/3, there's a lot of 1/3 in the care we provide people, and also for diagnoses. So one in 3 adults have hypertension, 1 in 3 adults do not know that they have hypertension, 1 in 3 adults can't keep their blood pressures under 140/90. That's a lot of people, right? And then the figure to the right of my screen is just talking about age-specific and age-adjusted prevalence of hypertension among adults. And so you can see, for example, overall 30% of people have hypertension. That's pretty equal between sex, the age distribution kind of listed, and obviously as you get older, there's more people. And that when you look at kind of race and Hispanic origin, that it's more common among non-Hispanic Black. And then chronic hypertension is pregnant in about 2% of our pregnant women these days. And the rate of maternal chronic hypertension has increased 67% from 2000 to 2009. with that largest increase of 87% estimated among African-American women. And what this particular publication did in 2022, there's a lot of people looking at the new classifications of the ACC-AHA, and I'll talk a bit about that. But before they adjusted the diagnosis of hypertension thresholds at, it used to be 140/90, and now it's 130/80. And so it's just looking at the change of the actual prevalence of hypertension. And obviously, if you lower that threshold, more people are going to classify as hypertension or hypertensive. So we all know that there's risks with pregnancy. So in pregnancy, when you have hypertension, so increased maternal and fetal complications, including death, preeclampsia, preterm birth, small for gestational age, and cardiovascular morbidities. But there's also risks beyond pregnancy, and there's risks in people who specifically had a hypertensive disorder in pregnancy. Those people are at higher long-term risk for chronic hypertension, cardiovascular disease, chronic kidney disease, stroke, diabetes, venous thromboembolisms, and vascular dementia. And this figure was also a more recent publication in 2020, looking at the incidence and long-term outcomes of hypertensive disorders in pregnancy. And their point was that when you look at individual people, which are those in this top left corner, it's underestimating the actual population risk of having these particular conditions and their outcomes. And so the other four figures here are just looking at the referent, which is somebody who doesn't have a hypertensive disorder of pregnancy versus a hypertensive disorder of pregnancy. And you can see that on that red line, those people who had hypertensive disorders have higher rates of long-term hypertension, coronary artery disease, and stroke. I think it's really important to talk about, like, what is blood pressure? How do you diagnose hypertension? And so we're going to kind of go through a whirlwind tour of that. And so there's a big publication, and I'll show you a picture of that. But it was in 2017 by American Cardiology and American Heart Association. And it really like revamped everything you'd want to know about high blood pressure, hypertension, how do you diagnose it, thresholds, et cetera. And this was sort of the key changer in reclassifying hypertension. So you can see the blood pressure category here is listed as normal, elevated, and then hypertensive at stage 1 and stage 2. And these systolic and diastolic blood pressure thresholds. And so I think the big thing to know and remember is that elevated blood pressure is between 120 and 129 and diastolic less than 80. Like, a lot of us probably think that's normal. And a lot of the patients you see, like, it's never even flagged because it's like, they're fine. And then hypertension stage 1 is actually the 130 to 139 and diastolic 80 to 89, with stage 2 being greater than or equal to 140 or greater than or equal to 90. And to diagnose hypertension, it should be greater than or equal to 2 careful readings obtained on a greater than or equal to 2 occasions of these thresholds for diagnosis. And I really like this figure because it's really trying to give you a visual of comparing non-pregnant and pregnant definitions of sustained and chronic hypertension. And what you can see on the top is that American College of OBGYNs has really not changed their classification. And so I feel like pay more attention to this one greater than or equal to 140/90. And so in a kind of old fashioned way, you know, we talk about, well, women have chronic hypertension if they have a threshold of this less than 20 weeks, or if they come in with a pregnancy that you know, they know they have that kind of threshold or diagnosis. And then we use, you know, classically like normal less than 140/90. And if it's over 140/90, they have hypertension, but then severe if it's over 160 or 110. And then the JNC7 old guidelines used to sort of follow that. And so you had normal pre-hypertension until you were at 140/90, where you then had stage 1. And then it was in 2017 with that American College of Cardiology and American Heart Association publication that really lowered this. And so really a normal blood pressure is less than 120/80. And after that, you have elevated and stage 1 starting at 130/80, like I talked about. And you can just sort of see where the definition we're using in obstetrics is actually stage 2 in non-pregnant people. So this is just a cover of that particular publication. It's very long, but it has everything you'd ever want to know. And one of the key points I also want to talk about and make apparent is that clinic blood pressures are not sufficient. So that really should be used as sort of like a screener that people have a concerning blood pressure value. But there's home blood pressure monitoring and ambulatory blood pressure monitoring, and I'm going to walk you through what those are. But the gold standard that everyone should be aware of is a 24-hour ambulatory blood pressure monitor to confirm what type of hypertension you have and that it's actually, clinical hypertension. And the values are different. So if you have a clinic blood pressure at 130/80, your home blood pressure monitoring at 130/80, daytime and nighttime ambulatory testing. But this ambulatory monitor is like a monitor you wear for 24 hours. Again, I'll talk about it a bit more, but if you're over 125, over 75, you also meet criteria for hypertension. And then you can also just see the variance at the different clinical thresholds of what you would expect on those other types of monitoring or testing. So we all hear about white coat hypertension a lot, and this is sort of just a plug that, like, if people tell you they have white coat hypertension, they need further assessment. Like, it's not okay to just say they have white coat hypertension. Every time they come in, it's high. Like, they really need to know, like, is this true or do they have chronic hypertension, right? So white coat hypertension is elevated blood pressure primarily in the presence of healthcare providers. It might account for up to 15% of individuals with office hypertension, but the exact prevalence is really not known, especially in pregnancy. And ambulatory blood pressure monitoring is beneficial to confirm that diagnosis and assist in decision-making for initiation of therapy or not. It also helps define, like, if people don't have chronic hypertension, they should be managed different in the context of their care. And if they do have it, well, then maybe they don't need medication. Like, you're over medicating people. So it's really important to understand this. And then there's a term called masked hypertension. So this is where people have a normal blood pressure in the clinic or office, but it's elevated outside of the clinic. So on that ambulatory testing or home blood pressure monitoring at those thresholds I talked about. And this is actually pretty common. So 1 in 7, 8 people, 1 to 7 or 8 people. And why does this happen? Well, it's probably a reactivity to daily life stressors and behavioral factors like smoking, alcohol use, contraceptive use in women, and sedentary habits. And this might selectively influence masked hypertension. And again, gold standard, ambulatory or home blood pressure monitoring. You only get a snapshot of what people actually are like when they're in the clinic. So how do you evaluate blood pressures and make the correct diagnosis? So I don't want to like detail all this out, but proper technique is so important. So it's not sufficient to just say, like, go home and check your blood pressures and not give people advice on how to do that properly. People really need to sit and rest for like 10 minutes. They need to sit with their legs uncrossed and their back supported. They really shouldn't be influenced by caffeine or tobacco. And they shouldn't have used it for about 30 minutes before testing their blood pressures. And then appropriately sizing their cuff. I mean, if you just tell someone to go buy one, they buy one and they might buy a medium or a large or whatever, but they really need to use the right size cuff for their arm. And so there is guidance on each machine and each cuff, but I use a paper measuring tape, and I'm always measure the arms, and I tell them their arm circumference. So when they're looking at buying one, that they get the right cuff for their body. And blood pressure cuffs that are too small will give you an overestimation of actual blood pressure. If you have to take a blood pressure in a recumbent position, they should really be on their left lateral decubitus position. And that level should still be at their right atrium. I think about this like all the time because most of the inpatient blood pressures, people are laying in the bed. And I've actually like removed people out of their bed and had them sit properly, and their blood pressures truly are very different. And I think it's really important to just be aware of the way that we're taking these blood pressures really influence their values and then the decisions we make. I have a lot of like educational material and resources that people could be using, and I probably haven't done a good enough job sharing these, but this is just an example of one that I've created, just blood pressure tips that you could be giving your patients to just help them have better technique. And, the last thing you want is to then get erroneous values reported and need to see people in your clinic because their blood pressures are too high, for example, and then they come to clinic and they're fine. So I think proper education goes a long way. So home and ambulatory blood pressure monitoring, the diagnosis of hypertension really should require integration of these two strategies, whereas routine measurements made in clinic really should primarily be used for detection purposes or people at risk. Again, like I said, I have a lot of different resources. I'll show you at the end. I have a website, but I've created videos on like how do you take your blood pressure at home and proper technique and what does this mean. For the purpose of today, this video is about 4 minutes. So I'm not going to play it. If we have time at the end, we could watch it, but I just want you to know that these things exist. So ambulatory blood pressure monitoring, I think when I say that term, I'm not sure how many people actually know what that really looks like. So this is just a picture of what that would look like. You wear this little monitor device you can put on your belt, or there's like a purse strap that you can wear with it, but it's actually, they place that blood pressure cuff on your arm and you wear that for a day and you wear it in everything that you're doing. So in most cases, you can like set how often you want these cuff readings to go off, but during the day, you should be doing like every 20 to 30 minutes and then about every hour at night. And then they take all these blood pressure readings and average over that 24-hour period to get the mean or average blood pressure. And this is the gold standard USPSTF recommendation for confirming a diagnosis of hypertension. It's tricky though, because really on campus, the only place that does this is at UW in cardiology. So the practicality of getting this testing done is challenging, but I do have all these devices and the equipment, and I'm hoping to be able to start offering this in our perinatal clinic. So this is an example of what a report would look like, and I'll just sort of walk you through this a little bit, but there's systolic and diastolic blood pressure on the figure on top. There's a daytime and a nighttime, and you can see all these different blood pressure values. And when you look at the brachial blood pressure results, you can see that this person had 78 blood pressures taken, and overall they were like 142/88 on average. But you can look at the awake period, the asleep period, the white coat period, and in particular dips. And then what you would get is an interpretive summary. And most commonly people use the 24-hour mean to kind of, or the daytime mean to kind of confirm that it's a particular type of hypertension. But you get a lot of information, and it allows you to make a real proper diagnosis. And then this is just another example of a report I pulled off the internet, but the reason for referral was really appropriate, suspected white coat hypertension. So they get 35 readings, and what did they find? During the daytime, their average was 142/87, which actually confirms that they have hypertension. So it really does make a difference. And then this is just a summary table to share with you. Blood pressure patterns based on office and out of office measurements. So when are people normotensive, sustained hypertensive, masked, and white coat? And it just talks here about, office clinical healthcare setting, they have it or they don't. And in the home and ambulatory setting, they have it or they don't. So I think it's just a nice table to refer back to. And again, all these tables are present in that big document in 2017 that I kind of showed you. So if people really want to know, it's all there. So I'm going to switch over here a little bit to management of chronic hypertensive disease in non-pregnant, and then I'll go through pregnant adults and the CHAP trial. I'm not talking about like what medications to use, et cetera. I'm just kind of talking like the global idea of management. So treatment of high blood pressure. So clinicians managing adults with high blood pressure should really focus on overall health of the patient, and then a particular emphasis on reducing the future risk of cardiovascular outcomes. So all patients with risk factors really need to be managed in an integrated fashion with comprehensive set of non-pharmacological like diet lifestyle modifications and pharmacological or medication strategies. Again, I know these like recommendations are kind of busy, but I think it's just important to like know where to find them and what they're saying. So recommendations for blood pressure treatment threshold and use of risk estimation to guide drug treatment of hypertension. So there's this risk calculator, which I'm going to show you on the coming slides. But if your risk of cardiovascular disease is greater than 10%, and you have it in the context of blood pressure, systolic and diastolic over 130/80, you really should be primarily started on pharmacologic treatment. The problem is that many of the people we see don't have that cardiovascular risk factor of like over 10% in the like age defining category that I'm talking about. And so their recommendation for treatment is really at 140/90, but you still need to encourage diet lifestyle modifications. And if those aren't working, you need to treat them with medications. And so it's just giving a little bit more time for them to try other interventions. So this is the ASCVD risk estimator. And, I encourage people caring for people to try this out, but it's, you need all these pieces of information, you plug them in. And then I did that, for example, for a sample patient. And what also is important is that this estimator calculator starts at the current age of 40. So if you have somebody less than 40, you're just supposed to put in 40. And then at the top, you'll see that current 10-year ASCVD risk. So like any person that I typically would care for keeps coming. I did this like multiple iterations, and a lot of them fall under 10%. But it helps you kind of understand that for your patients. And as I just mentioned, putting in 40 if your patients are less than 40, but if you have patients who are older than 79, you can just assume that their 10-year ASCVD is over 10%, and they should all be managed at that 130/80 threshold. And then this is just an algorithm that I think a lot of people these days like checklists and algorithms, but if you start at the top, so there's blood pressure thresholds and recommendations for treatment and follow-up. So we have our normal people, and if you see there in yellow, like you really should have your blood pressure checked every year. Just because you're normal doesn't mean that you don't need to keep an eye on your blood pressure. And then if you have that elevated blood pressure, you should really be reassessed in 3 to 6 months. Stage 1, I just talked to you about using that calculator for your patients, but then using non-pharmacologic therapy, you really still need to reassess them in a tight timeline. And if they have, that risk over 10%, starting medication and kind of following the rest of these. But stage 2 really is a combination of starting medication and non-pharmacologic therapy. And then what do you do once you diagnose initial blood pressure elevations or hypertension? You have to keep following these people. So just like that algorithm showed, if they are going to be in that lower risk category, seeing them in 3 to 6 months or having some sort of follow-up, but people who need to start on medications really need to be rechecked in a month. So I just kind of want people to be aware of those timelines and follow-up. So let's review current recommendations for management of non-pregnant and pregnant young adults with chronic hypertension. This is moving towards pregnancy now. So ACOG practice bulletin, we have one on chronic hypertension. It has not been updated with the exciting new results that I'm going to go through here. But historically, antihypertensive therapy in pregnancy trials for non-severe chronic hypertension, meaning blood pressure is less than 160/110, have not shown benefits for pregnancy outcomes. There's been safety concerns specifically on growth of the baby and low birth weight. And there's been few randomized control trials. They've been underpowered, and there's design limitations. And so recommendations for the non-pregnant population really don't follow the same recommendations in pregnancy, and then benefits and safety in pregnancy were uncertain. There's conflicting recommendations for internet and international controversy for, again, management of that non-severe chronic hypertension. So we just published this paper in the New England Journal of Medicine. So hopefully a lot of you have heard about this, but it's titled Treatment for Mild Chronic Hypertension During Pregnancy. And the basis of this publication is our CHAP trial. So this was a wild trial to participate in that took a lot of people and a lot of effort and a long time to complete, but so essential in the ability to actually provide evidence-based care and improvement in care to our patients. So it was an open-labeled randomized control trial that took over 70 centers in the US. The clinical coordination and data coordination always through University of Alabama and funded by NHLBI. And the primary aim of this study was to evaluate the benefits and safety of antihypertensive therapy for specifically mild chronic hypertension during pregnancy. And our hypothesis was that antihypertensive therapy to a blood pressure goal of less than 140/90 for non-severe chronic hypertension during pregnancy reduces the frequency of adverse outcomes associated with chronic hypertension without increasing small for gestational age. Inclusion criteria included mild chronic hypertension that was new or pre-existing, and a singleton pregnancy. And then it was 20 weeks, again, thinking about to have chronic hypertension based on ACOG's rules, you had to be diagnosed less than 20 weeks. But we know that 20 to 23 weeks, many of these folks had chronic hypertension. There was a lot of trouble, getting enough patients and people being excluded. And so over time, it was included to include women up to 23 weeks. Exclusion criteria was severe chronic hypertension or being on more than 2 antihypertensive medications at baseline. Secondary chronic hypertension or kidney disease, any high-risk medical comorbidities with advanced diabetes or end organ effects, fetal death or major anomalies, and then allergy to blood pressure medications. So for randomization, clinic blood pressures, if people were untreated, meaning not on a blood pressure medication, they had to have a blood pressure that was in the mild range to meet criteria to randomize. However, if they were on medications, they could just be included. It didn't matter what their blood pressures were, but they had to be a less than 159/104 and adherent to their medication therapy within 24 hours. So this is important to understand because it was very hard to find people who were untreated with chronic hypertension that actually had high blood pressures before that 20 to 23 week time period. And so it was like one of the most common reasons that people were unable to be randomized actually. So the treatment protocol, so in the active arm, blood pressure target was to be kept below 140/90 for the entire gestational time after randomization. We were allowed to use labetalol or nifedipine ER. However, again, as the trial went on, they opened it up so people could use whatever medication they were on or if they had better control on those. But the labetalol and nifedipine were provided free at charge to the patients throughout the whole trial. The other medications people had to, pay for themselves. And then medications were titrated at visits if adherent, and a second agent was always added if necessary. And in the standard arm, so these folks' treatment was withheld or discontinued. So they were not on medications and they were only on medications if their blood pressures were over 160/105, which is what the current guidelines suggested to do. And then the blood pressures were titrated to stay less than 160/105. So that was hard too. Like people who are on medications, you tell them you're gonna have to stop these medications and we're not gonna treat you until this period of time. And as an investigator, it was hard for me to follow that because the way I was trained was to very aggressively treat blood pressures. So it's just interesting being an investigator. Like that's actually what the evidence says. It's okay to do this, but like you felt conflicted, but it was an important question to answer. So when you have chronic hypertension, I talked about exclusions, and then I talked about the randomization arms, and then there's the outcomes of interest. So our primary outcome was a composite, and it was a combination of 4 different things. So preeclampsia severe features, and that included up to 2 weeks postpartum, and indicated preterm birth less than 35 weeks, placental abruption, or fetal or neonatal death. There's this little note here that says centrally and blindly adjudicated. I also think it's important. So I was really involved in this trial, and in this particular primary composite outcome for every patient was adjudicated by 2 reviewers separate from the whole study. And so we had to go through all the medical records and confirm that these diagnoses were correct. And so it was intensively monitored and confirmed. And sometimes when we actually reviewed the charts, the diagnosis was different. So the safety outcome was that small for gestational age. The study was not powered for this outcome specifically, but it was looking at small for gestational age at less than the 10th percentile and also the 5th percentile. And then there was a lot of secondary outcomes, and there's so much data that even more and more things will come out over time, but specifically maternal cardiovascular complications, including death or ICU admission, stroke or encephalopathy, congestive heart failure, pulmonary edema, myocardial infarction, acute kidney injury, and preeclampsia. And then preterm birth, serious neonatal morbidities like bronchopulmonary dysplasia, retinopathy of prematurity, necrotizing enterocolitis, and interventricular hemorrhage, specifically grades 3 and 4. So for our sample size and analysis, this was an adjusted sample size, which is kind of interesting, but when they did their interim analysis, they looked at the actual incidence and kind of outcomes, and they were able to lower the overall sample size, which we'd still be working on this if they weren't able to do that. But there was over 85% power and 25 to 33% relative reduction and 30% baseline incidence, 10% crossover, 5% loss, and a two-sided alpha of 0.05. And our statistical plan included imputation for missing values and sensitivity with a complete case analysis. So for results, we screened 29,771 people and had to exclude 27,352 people. So like I said, it's very hard to find the right people for this study. We included 2,408 over 61 sites across the country. And then they were allocated in active and standard arms, and then outcomes available on 97 and 96% of our participants. Here's a table of baseline characteristics. They were balanced between the two groups, but information known on, the type of chronic hypertension, which most commonly people were known on medications. And as I alluded to, like, it was much easier to include them because it didn't matter what their blood pressures were, they were on medications. A lot harder to find people with a new diagnosis or people who had known chronic hypertension that weren't on meds. Age at enrollment was about 32, and we had a good distribution of race and ethnicity, and a good representation of Black non-Hispanic people as well. You can see that we had information on mother's insurance, BMI at enrollment. Most people for the gestational age at enrollment, about 40% happened before 14 weeks, but a lot of them after that time point. We did have people with diabetes as well. And then if you're just curious what medications were used, so everybody wanted to use labetalol, and at one point they were like, please use nifedipine. But 61% of people were put on labetalol, 35% on nifedipine, amlodipine, and then, variety of other people on other things, but amlodipine, methyl-dopa hydrochlorothiazide, and others. This is just a pictorial figure on what blood pressures looked in our treatment versus standard arm groups. So this is weeks after randomization on the bottom, and then systolic and diastolic blood pressures on these two panels. And what you can see is a standard arm is in blue and the active treatment arm is in red. And you can see that the people who are managed lower, obviously their blood pressures were lower until towards the end. So for that primary outcome on the maternal composite, like I talked to you about, there was a significant reduction in that composite primary outcome. So in the active arm, it was 30% versus 37%, and that was significant. And this is just showing you those numbers and the specifics of each of those composite outcomes. So the composite together was significant, but additionally, the reduction in preeclampsia, severe form, indicated preterm birth, were also independently significant. And then our safety outcome of small for gestational age is important, that like we improved outcomes for the mom, but we did not increase the risk of small for gestational age of the baby, which again, for historical reasons and for many years of counseling, like we were like, well, your baby might be smaller, so let's not treat, these blood pressures until they're severe. So we did not find that there was a difference in babies less than the 10th percentile or the 5th percentile. And then I talked to you just about the other maternal outcomes of interest, and there was no difference in the treatment arms on those other comorbidities. And then when you look at any type of preeclampsia or hypertension, sorry, I have something covering my screen. Worsening chronic hypertension. Sorry, give me a second. So any type of preeclampsia, organ dysfunction, and then severe hypertension were all reduced in the active arm. And then looking at neonatal outcomes, we also showed that there was a reduction in preterm birth less than 37 weeks and low birth weight, less than 2,500 grams in the active arm. And then furthermore, looking at other neonatal outcomes, we did not find that there were any differences in these other neonatal outcomes we talked about. Again, treating people with medications or at a lower threshold didn't seem to affect the baby on these things either. So in summary, treatment of chronic hypertension to a blood pressure threshold less than 140/90 decrease adverse pregnancy outcomes in that primary composite. The number needed to treat was 14.7. And then it doesn't impair fetal growth, and there's no other maternal or perinatal harm. So strengths of this study was that it was multi-center, large size, there's racial ethnic diversity, and there was central adjudication of all of these outcomes. So in conclusion, CHAP supports the treatment of chronic hypertension to a lower blood pressure threshold of less than 140/90 in pregnancy. And people who come to you on medications, you should continue their established antihypertensive. And long-term studies are going to further clarify treatment effects. So we have a long-term maternal follow-up of these patients already funded by NHLBI, and the childhood outcomes that grant is pending. So there's a lot of people to acknowledge NIH, NHLBI for funding the DSMB patients, faculty, clinical trainees, and staff at all sites, study teams at clinical sites. And there's a lot of co-authors here as well. So I'm just going to move on from CHAP a little bit here to talk a little bit about, like, so we have a big trial that comes out like that, and what changes to hypertension management should we expect, in the future. So this is a summary document that was put together by Dr. Tita, who's the primary investigator of this trial. It's a research summary that I thought, just bringing awareness to you, you could use with your patients if you'd like, but it just goes through the, exactly what I just talked about in a one-pager. So I have never seen clinical practice changes and recommendations to change happen so fast. Like literally this happened, and SMFM and ACOG have already both put out summary statements and recommendations on what to do, which I think is huge. So this, I just pulled out of kind of their summary statement, but it basically just says, based on the available evidence, SMFM recommends treatment with antihypertensive therapy for mild chronic hypertension in pregnancy to a goal less than 140/90. And furthermore, ACOG put out a statement as well, and they say, based on these findings, ACOG recommends utilizing 140/90 as the threshold for initiation or titration of medical therapy for chronic hypertension in pregnancy rather than the previously recommended threshold of 160/110. And it also even states that patients who are on medications at the start of pregnancy, in the absence of other mitigating factors or side effects, can be maintained on their meds. And I just find it so fulfilling that we did this trial and we had these results, and that there's immediate backup of this practice change. And I think it's important, and half of doing this talk today is just disseminating the information so we can all provide the best evidence for our patients. And then a little bit about postpartum long-term cardiovascular health, like now what do we do? So, as I started, we talked about, like, there's a baseline, there's a pregnancy, there's follow-up care, there might be another pregnancy. But what is clear in the literature is that people who have had adverse pregnancy outcomes, and then specifically if you look at like preeclampsia or gestational hypertension, there's a future cardiovascular risk there. And I really like this figure. And that was published recently in 2021. But it's looking at team-based care of women with cardiovascular disease from preconception through pregnancy and postpartum. But this figure is pretty cool, because if you look at the heart and you look at these diagnoses to the left, and then all the different, cardiovascular issues that come up for people with preeclampsia and gestational hypertension, every single one of those are significantly elevated. And I didn't focus on the ones below, but any of those empty boxes just hasn't been studied or published on. But it's a clear risk factor for people that I think we need to start paying attention to and notating in the care moving forward in any primary care that they have after a pregnancy affected by one of those diagnoses. So I really want to advocate for referral for postpartum hypertension care and follow-up. And I think a lot of people are aware, and I'm really not talking about this much today at all, is our STACK program. So this is what we call postpartum telehealth, but we've coined it as staying healthy after childbirth, or we call it STACK. And I just pulled out a little bit of our data, and actually my whole nurse team is amazing, but they're helping with different QI initiatives. And one of them is that, maybe you know, maybe you don't know, but anybody who has residual hypertension at the end of our monitoring period of 6 weeks, we put in a referral to a PCP that might be a family med doctor or an internal medicine doctor, because if it's left up to us as the OB providers, many of us aren't referring our patients. But despite our like intensive efforts to do this, I took a 6-month chunk of time where we took care of 663 people. 108 had residual hypertension, and we placed referrals, which is about 20% of the people that we followed. And only like 38 of those women, or 30%, scheduled an appointment, and 29% attended that visit. And 60% didn't even schedule an appointment. So it's like, we think we're doing something, but are we actually like effectively making change? And then at least half of them didn't have a visit at 1 year either. So we have to do better. I recently met with the Preeclampsia Foundation and became aware of this really great 5-page document that they have, and it's available publicly, and we're all able to use this. And I'm going to start deploying it actually in our STACK program, so all women will get this and have it. But it's pretty cool. So making a plan, my health beyond pregnancy, it has like a section that they fill out for themselves, a section about like, what was my pregnancy complicated by and what did I have? And then it's making a plan to follow your blood pressures after, and putting this in the hands of the patients so they can be empowered to take control of this and be aware of this, but also to take this to their providers and be like, I'm following this, I need this follow-up, like I really want to watch this. So it has areas for blood pressure values at 6 weeks, 6 months, and 12 months after delivery. There's information here on body mass index, which losing weight is one of the best ways to change your kind of cardiovascular risk, as well as lower your blood pressures. Some advice on how they can change their life, for the better, and improve their long-term outcomes. And then this last form, I think as a department, we should work on this, but seeing people and making sure that they get their evaluation at 1 year postpartum, and assessing these labs that are important, screening for diabetes and urinary protein. And these are also values that are important to use for that cardiovascular risk factor calculator that I showed you. So I want to make sure everybody was aware of this, and that if patients start bringing it to you, it's because I think it's at least a start in the right direction. And this is just right off the Preeclampsia Foundation website, but schedule an annual visit with your primary care provider. We're not doing a good job at doing that. And if a lot of patients are coming to see you for a 1 year PAP or GYN visit or whatever, like we really also need to be thinking about blood pressures. This is a really busy slide, but it's really for providers and helping define a care plan for the patients that you see that have had a hypertension related issue in their pregnancy, or I think can really be also applied to people who have not had a pregnancy yet. But taking time to familiar yourself with these recommendations, again, hopefully I've brought some of this to the forefront today in this talk, listening to your patients, connecting them with resources, making sure that their pregnancy history, especially if it was affected by hypertension, is in their ongoing medical records, and that's taken as a risk factor for long-term cardiovascular disease. Making sure that transition of care from postpartum, that their blood pressure readings are addressed. If they're not controlled, that they get referred beyond. We can use this tool to help empower the patients and encourage blood pressure tracking at home. Lastly, I just want to give you a little blurb about this young hypertension management and this unique position that I've been in to learn a lot more about this. But I have an R01 funded trial that's called My Heart. And what My Heart is it's called My Hypertension Education and Reaching Target Program. This was designed for an effective strategy for young adults with hypertension, again, that age of 18 to 39, a team-based hypertension self-management intervention that was informed by pilot young adult providers and healthcare administrators. That includes 4 evidence-based self-management components. So it was telephone-based health coaching with an adult education specialist to teach and monitor self-management skills, electronic health record documentation of coach-patient telephone contacts, individualized hypertension education materials, and home blood pressure monitoring. And what we did with that MyHeart program was to conduct a randomized control trial in 2 large healthcare systems, which was here and Aurora in Milwaukee, to evaluate the impact of MyHeart on blood pressure among 310 geographically and racially diverse young adults, looking to see if we could change systolic and diastolic blood pressures at 6 and 12 months with young people who had uncontrolled hypertension. This is males and females. We also were looking to see the effect of MyHeart self-management on behavioral outcomes, and also to look at the effect of self-management behavior mediated through perceived competence, autonomy, and motivation. I already kind of a little bit told you about the inclusion criteria, but 18 to 39, they needed to have hypertension confirmed in their clinical records, be medically homed in our healthcare system, or the 2 healthcare systems. And then they would come, we identified these patients, and then we would send them an invitation to our study, and they would come in for 2 visits where we actually did that ambulatory blood pressure monitoring that I talked to you about to confirm the proper diagnosis. And after coming back and confirming that diagnosis, that it wasn't MAST or white coat, they were included in the trial if they were eligible. And this is just a schematic study design of like all of what I just sort of tried to talk about, but identifying these folks, randomizing 310 people to the intervention or the control. And then I think the cool thing is that this MyHeart intervention, we had 6 months of 12 health coaching calls, so every 2 weeks. And then looking to see if that made a difference with home monitoring at 6 and 12 months compared to people who just got a pamphlet on hypertension and were kind of told to just go handle this yourself. They didn't get a blood pressure device or anything. It was just following conventional care, which would look like you're told you have high blood pressure and, you know, see what you can do about that diet, lifestyle, etc., and then see us in 6 months. So for this result, stay tuned. I do know the answer to this question, but I have to publish it before I can really publicly talk about it, but that's really soon to come. So next steps, I just want to throw out a plug for a couple of things that I think would be really amazing for our patients. And one of that would be from this MyHeart trial, I still have a health coaching kind of team and a lot of strategies that we could apply, you know, maybe outside of our STACK program. So I'm sort of thinking about next steps and considering that, like whether women with just having preeclampsia, like could we provide health coaching to them and follow them to that 6 and 12 months and really make sure that that's intensively done well. Maybe we can make a change. And then maybe a consideration of a multidisciplinary preventative cardiovascular clinic. And this year, I just want to shout out to Dr. Gaston, and I hope he's on this call today because he's constantly advocating for the people we care for and cardiovascular disease and risk reduction. And both these little blurbs, this particular abstract saying, you know, a care clinic like this can really improve outcomes for interpregnancy and subsequent pregnancy outcomes. And then, you know, another paper, team-based care of women with cardiovascular disease from preconception through pregnancy and postpartum. Both these Dr. Gaston sent to me, and he's like, we need this clinic. Like, how do we get this? I'll volunteer my time. So I really think there's a ripe environment to do better and to work together. And I know there's people interested in this as well. We, from my STACK program, had a dissemination implementation grant that allowed us to create a whole website. I have, you know, videos on what do we do. I have patient attestations. I have a whole bunch of like training and handouts that we give our patients in STACK, but that other people could start using if they're interested. You can go to this website. It's stackathome.org. And there's sections there about healthy choices in and outside of pregnancy. There's a calculator I created for predicting risk of readmission. So I encourage everyone to like look there. If there's things you want there that we could build out further, you know, let us know. And with that, I just want to thank everybody. There's some hard numbers here about why we should all care about our patients inside of pregnancy and outside. And really, I think working together as a team, we can make a big difference. Thank you.
That was really great. We'll open it up for questions or comments or anything in the chat. This was very impressive, all of the work that you've done, all of the programs that you've implemented here for our patients.
Dr. Hoppe, this is Maya Gross. I have a question about management on labor and delivery of patients with chronic hypertension. I feel like we often have people that are sort of teetering on the edge of severe range hypertension. And I feel sometimes confused about whether to increase their meds if they're in the 150s during labor. Can you talk on that at all or give us some guidance on how to best do that?
Yeah, I just want to clarify, you're asking about non-chronic, like just gestational or
No, people with chronic hypertension. Like obviously with gestational, we don't start people on meds, but if they're chronic and they're close to severe, I feel like sometimes we're still worried or people are worried about masking severe preeclampsia by increasing their meds.
Yeah, I think so. I totally hear what you're saying. I think with the with this trial and with SMFM and ACOG to back it up, you should no longer wait for anyone to have severe hypertension if they have a diagnosis of chronic hypertension. And how do you get around figuring out if they have preeclampsia or not? Well, everyone should have a baseline urine protein. So if you're seeing an extraordinary change like in their baseline protein or lab changes or symptom changes, or you're needing to like escalate their medications rapidly, those are like ways that you should, alter your care plan. And but I don't think anyone should be scared of treating people with chronic hypertension. Frankly, if you don't, you're going to have worse outcomes. So those folks should stay less than 140 over 90. I think it's a little bit harder on the acute side when they're in labor, because that's not like talking about kind of the long-term benefits and like the whole pregnancy, being high. So I think I'm not really suggesting changing their oral meds in labor, but you may get benefit out of that if it's a long labor, if that makes sense. But otherwise, I would default to like your emergent treatment of severe hypertension with IV meds as needed for those folks in that acute position. And then I just want to say also that people are thinking about how do I apply this to gestational disease and preeclampsia. And I think that's going to be a harder hill to climb because we're worried about exactly what you said. Do they have preeclampsia? Do they not? Do they have severe? Do they not? So I think there are people already applying for funding to apply this to like gestational disease, for example. But I think that's going to be a harder thing to implement and like nuance on what to do, if that makes sense. So hopefully that answers your question.
Yeah, thank you.
Thanks for the question.
Kira, this is Katie Sampene. I was just wondering, so we have, the story a lot where someone comes in to pregnancy, they might have some risk factors for hypertension, and lo and behold, their blood pressure at their new OB is like 130 over 90. Mm-hmm. And they're, of course, they're sure they don't have chronic high blood pressure and they've never been told they had it before. I'm just thinking, like, with this information that you shared today, what would my next steps be as a provider? And would you kind of advocate at that point for getting them plugged in with the home cuff and kind of all the instructions that you shared with us that are really helpful for making sure those are accurate? Or would you kind of advocate for getting them to cardiology to try to do that 24-hour ambulatory test? Like what, given, system constraints and things, what would you do when that situation comes up?
Yeah, so I think one thing, and again, I'm a visual person, but having that figure I showed you about like ACOG definitions and then, the ACC and AHA definitions, like people will often say like, well, I have high blood pressures, but I don't have hypertension. Like it's been very interesting to learn about the words people associate with. So I think number one, like being confident, like you have prehypertension or like you have, elevated blood pressures or you have stage 1 hypertension in a non-pregnant state. What we don't know necessarily is that, and what people don't qualify for these young ages is necessarily like pharmacologic treatment. And so when you're thinking about what to do, I think, and versus like what to treat, I think is different questions, but I think so it's complicated here. So I think confirming what they have, tell them that they should start monitoring their blood pressures at home. The tricky thing is like blood pressures might be high and then they go down 5 to 10 millimeters of mercury until that, second trimester. So awareness of home blood pressures, I think, is important. Doing them at home, considering that 24-hour ambulatory test. Hopefully we can start doing that in our clinic just to confirm what they have or they don't have. But the real thing is like, if they have stage 1 hypertension, so that's less than 140/90, most of our patients are young, right? So they're not going to qualify necessarily for treatment right away. But if their blood pressures go over 140/90 in the pregnancy, you should put them on medication based on the CHAP results. And also we know there's a lot of people that are looking at, if you're that 130/80 to 140/90 person, those people have worse pregnancy outcomes, higher rates of preeclampsia, et cetera. So ACOG sort of says like, we know this, we hear this, but like, what is the true benefit of treating somebody less than 130/80? And we don't know. And we're going to look secondarily at that in our CHAP cohort. But right now, all I can say is I think it's important to like put in their chart, they meet criteria of stage 1. That wouldn't really alter the way I care for things right now. You get your baseline labs. If you can get an ambulatory blood pressure test, awesome. Home blood pressure monitoring also is a very good second next step. It's still hard to get people devices, but try teaching them self-awareness, letting them know their risk is elevated and that they're going to need to have long-term follow-up. And then I would just say, because it alters decision-making and timing of delivery, et cetera, like they have chronic hypertension based on these guidelines. However, ACOG doesn't support treatment, until they're 140/90. So that's sort of how I'm thinking about it right now. Be open to like other thoughts, or I hope that's kind of helpful guidance.
Yeah, that's super helpful. And it sounds like maybe try to get them into cardiology for that referral test. And if they don't have the capacity, they'll obviously tell us or something.
Yeah, so the key about that actually is they don't go to cardiology. There's just an order in HealthLink. It's an outpatient lab. You just put that in, they go there, they don't see a cardiologist, and the interpretation will pop up. So I'd be happy to like walk through those results if you order this on anybody. But again, hopefully in this year, we can get this going in our clinic, and we can see them for a consult or do that testing for you. But it's not done through a cardiologist or cardiology clinic. It's just a lab over there. And I can send out what that lab name is, but it currently is only being done through that lab at UW.
Thank
Cool,
you so
thanks.
much.
That's really helpful.
Yeah, thanks so much, Dr. Hoppe, for presenting today. I think we're out of time here, but if anyone has further questions, feel free to reach out to Dr. Hoppe. But thank you so much. This was really informative, I think, for everyone. So
Hope you enjoyed it. Have a good day.
thanks.